In the trenches. Today I was asked to talk about acute coronary syndromes. This is a very long topic. I'm not a cardiologist. I'm going to try and make this brief and dumb it down. Okay, acute coronary syndrome, that's a STEMI, non-STEMI, and something that we used to call unstable angina, and maybe a little more than that. And we have very sensitive biomarkers. The mechanism of acute coronary syndrome is either plaque rupture or plaque fissuring. There are other mechanisms, these are the most common, where there's something in the plaque, and these patients may not have 90% stenosis. They could have 40 or 50% stenosis, and something within the plaque causes it to rupture. It occludes a coronary artery. These are the mechanisms. It used to be many years ago, before probably just about anybody watching this video was born, they used to think of it more of a supply-demand problem, which is the case with stable angina. STEMI, you have ST segment elevations, and non-STEMI, you don't. Unstable angina was a characteristic which I learned it was either new onset angina, angina at rest, or change in the severity or duration or length of their prior angina. If you get troponins from a lot of these patients, they're elevated. So you have very high sensitive troponin. And basically, you're following these people in the ER, you're trending them, and you're looking for a delta, and you're looking for them to go up. Now, that's the basic mechanism, okay? The time-honored principle in treating acute coronary syndromes or acute MI, time equals muscle. The quicker you get in and intervene and save muscle, because the most important factor, prognostic factor, post-MI is your residual LV function. There are other things like the extent of CAD and the presence of arrhythmias, but really the most important thing is residual left ventricular function. So, as STEMI, you have ST segment elevations. Now, other things cause ST segment elevations. You could have a STEMI, you could have Prinz-Metal's angina, which is coronary artery spasm, acute pericarditis, an LV aneurysm, or a CNS catastrophe, or severe hyperkalemia, or something called J-point elevation. So everyone with ST elevation, normally with a STEMI, you're going to see concave down ST segment elevation. With the pericarditis, it's going to be concave up, and it's going to involve most leads. And you go through a period of time where they change from ST segment elevation to flatline to T-wave inversions back to flatline. Isoelectric EKG. Something with the pericarditis, you can see PR depression, and that's called Spodek sign. Named after David Spodek, cardiologist from Massachusetts. Prinz-Metal angina is coronary artery spasm, where you see the ST segment elevations and you give them nitroglycerin and they resolve acutely. More often than not, these patients have underlying coronary disease. An LV aneurysm, and we don't see these much now, is when you have ST segment elevations and they don't go down following an anterior apical. CNS catastrophes like subarachnoid hemorrhage, intracranial bleed, that's not really part of this talk. That could do it. The other thing that could do this, though, is something called J-point elevation. So the end of the QRS complex is called the J-point. And in certain people, like young, thin males, the J-point might be elevated. And that's what's normal, and for some reason they have very large T waves. Okay, The other thing about large T waves, when you're having a STEMI, the first thing you can see is a change in the T wave. They can be very large, okay? And unlike hyperkalemia, they're not symmetrical. And these are called hyperacute T waves. Okay, anyway, that's ST segment elevation. Non-STEMI is they have a syndrome, they have chest pain. The troponins positive, usually their EKG changes, but they don't have ST segment elevations, usually not always. They're smaller MIs. So, without going through the history of all this, what do? Somebody presents in the emergency department, you have to interact with them right away, and this has evolved a very efficient process. Someone's having a STEMI, you're going to get them up to the cath lab and you're going to do an angioplasty and stent. You're going to intervene. Back in my day when I was a resident, they started using thrombolytic therapy, okay? And really, the first study that really gave note was the TIMI trial, which showed the first thrombolytic agent was streptokinase. And that showed to open up arteries with the Giese study. And then TIMI-1 showed that TPA opened up twice as many arteries as streptokinase. And then in 1993, the Gusto trial showed that TPA actually saved more lives than streptokinase. And that what was used until the mid-90s when they started comparing angioplasty. With angioplasty, they went through just first you had angioplasty, then you had angioplasty, which had a high incidence of restenosis, then you had angioplasty with stents, and then you had angioplasty with drug-eluting stents, is what they have now. Okay, defining MI. You know, the way you define MI, type 1 MI is classic plaque rupture or fissuring. Type 2 is injury supply-demand mismatch. Often you see in hospitalized patients, they're tachycardic, they're septic, they have rapid AFib. There's an imbalance between supply and demand. Type 3, sudden death. They have an MI, they died. Type 4 is post-PTCA, post-intervention, where the troponin goes up threefold. And type 5 is post-CABG, where troponin goes up fivefold. Of the type 4, there are three things. Okay, there's in-stent stenosis, okay, restenosis, but there's something called stent thrombosis, which is potentially lethal. And that's why these patients need to be on antiplatelet therapy, and they need to be on that for at least 3 months to prevent in-stent stenosis. So that's part of type 4. That's how you classify it. So when you're seeing these patients, when they present initially, you'll identify them. Often they're placed on heparin. They may be placed on nitroglycerin. If they're not in heart failure, given them beta blockade, and this history goes back to the 1970s and early 1980s, where you're decreasing the MVO2, which is the myocardial O2 demand, decreasing how much it needs in order to stabilize things. And then they're getting these people up to intervention right away. If they're not on aspirin before that, you're going to give them an aspirin also down in the ER. There's data now that if they're not hypoxic, then you don't need to give them oxygen. If they're hypoxic and pulmonary edema or whatever, then they'll need oxygen. And really for MI pain, not angina, but MI pain, morphine's what works for the pain of an MI. If you give somebody a sublingual nitroglycerin and relieves the pain, that tissue's still alive. Anyway, this is a very quick talk on unstable angina.